Hello everyone, in this session I'm going to talk about the heart conduction system. The heart conduction system is a specialized network of cells that generates and conducts electrical impulses, ensuring the heartbeats in a coordinated and efficient manner. The key component of this system are sinoatrial node or SA node located in the right atrium, acts as the natural pacemaker of the heart, initiating electrical impulses. And atrioventricular node or AV node located at the junction of the atria and ventricles delays the impulses from atria before passing into the ventricles, allowing time for the atria to contract and fill the ventricles with blood. Another component of this system is bundle of His or atrioventricular bundle, a pathway that transmits impulses from the AV node to the ventricle, and right and left bundle branches conduct impulses through the interventricular septum to the ventricles. Finally, the Purkinje fiber is a component of this system, spread throughout the ventricle, causing them to contract and pump blood to the lung and the rest of the body. The conduction system ensures that the heart contracts in a synchronized manner, maintaining effective blood circulation. The electrical impulses travel through the conduction system, leading to the contraction of the heart muscle. The conduction velocity varies significantly among different tissues in the heart. For example, in the Purkinje fiber, the conduction velocity approximately is 4 to 5 meters per second. Rapidly conducts impulses to the ventricle myocardium, ensuring synchronous contraction of the ventricle. And in the atrial muscle, conduction velocity is about 0.3 milliseconds, conducts impulses from the SA node throughout the atria, allowing for coordinate atrial contraction. And in the atrioventricular node or AV node, this velocity is around 0.05 meter per second, and delays the conduction of impulses from the atria to the ventricle, allowing time for the ventricle to fill with blood. And in the ventricular muscle, conduction velocity is approximately 1 meter per second, conducts impulses through the ventricle walls, leading to contraction and ejection of blood. and the bundle of His or bundle branches conduction velocity is about 1 to 2 meter per second, and transmit impulses from the AV node to the Purkinje fiber and down the interventricular septum. The Purkinje fiber have the highest conduction velocity, which is crucial for the rapid spread of electrical impulses throughout the ventricle, facilitating effective pumping action. And the AV node has the slowest conduction velocity, serving as a critical delay point in the conduction pathway. This variation in conduction velocity is essential for the proper timing and coordination of the heart contraction. And as you must know, the highest conduction velocity in Purkinje fiber are related to the large number of gap junctions between their cells. The SA node is heart's natural pacemaker and has the self-excitation feature. The phonic current and resting membrane potential near to the threshold in the sinoatrial node are important aspects of pacemaker activity of this node. Phonic current, also known as the pacemaker current, is a depolarizing current that flows through a specific type of the ion channel called the hyperpolarization activated cyclic nucleotide gated or HCN channels in the SA node. These HCN channels are activated by hyperpolarization, more negative membrane potential, and allow the flow of sodium and potassium ions, causing a slow depolarization of the membrane potential. The phonic current helps generate the spontaneous diastolic depolarization that leads to the action potential in the SA node, which then spread throughout the heart. In the SA node, the resting membrane potential is around minus 55 to minus 60 millivolts. As the phonic current slowly depolarizes the membrane potential, it reaches a threshold of around minus 40 millivolts. At this threshold potential, the L-type calcium channel in the SA node open, allowing a slow influx of the calcium ions. This influx of calcium ion triggers the action potential, which then propagates through the rest of the cardiac conduction system. So the combination of the phonic current and the resting membrane potential near to threshold potential is crucial for a spontaneous and rhythmic firing of the SA node, which serve as the natural pacemaker of the heart. The AV or atrioventricular delay is an important aspect of the cardiac conduction system, which enables the coordinated contraction of the atria and ventricle. The action potential stays in the AV node for approximately 0.12 seconds before reaching the ventricular. The AV delay enables the atria to contract and complete their filling of the ventricles before the ventricles start to contract. This ensures that the blood from the atria is effectively pumped into the ventricle before the ventricular contraction occurs. The AV delay allows for the efficient and coordinated pumping of blood from the heart. It ensures that the atrial contraction or atrial systole precedes the ventricular contraction or ventricular systoles, optimizing the filling of the ventricle and the overall cardiac output. As a whole, the AV delay of approximately 0.12 seconds in the cardiac conduction system is a crucial timing mechanism that enables the atria to contract and fill the ventricles before the ventricles themselves contract. This coordination between the atria and ventricle contraction is essential for the efficient and effective pumping of the blood throughout the body. There is a one-way direction of signal conduction in the AV bundle is due to the presence of a layer of fibrous tissue known as the annulus fibrosus between the atria and ventricle. This fibrous tissue acts as an electrical insulator, allowing the action potential to travel only from the atria to the ventricle, but not in the reverse direction. The action potential in the AV bundle travels only in atrium to ventricle direction. This one-way direction of signal conduction is caused by a layer of fibrous tissue, the annulus fibrosus, located between the atria and ventricle. And the fibrous tissue acts as an electrical insulator, preventing the action potential from traveling back from the ventricles to the atria. This one-way conduction is an important feature of the cardiac conduction system, as it ensures the proper timing and coordination of the atria and ventricular contractions. The sinoatrial node, atrioventricular node, and Purkinje fibers all have the ability to generate a spontaneous action potential. However, in the normal states, the SA node acts as the primary pacemaker of the heart, and its firing rate is higher than the other pacemaker region. The firing rate of the different pacemaker regions are SA node 70 to 80 beats per minute, AV node 40 to 60 beats per minute, and Purkinje fiber is 15 to 40 beats per minute. The higher firing rate of the SA node ensures that it generates action potential before the other pacemaker region, thereby overriding their spontaneous activity and establishing the SA node as the dominant pacemaker. This hierarchy of pacemaker activity is essential for the coordinated contraction of the atria and ventricle. The SA node's faster rate ensures that the atria contract first, followed by the ventricle, allowing for the efficient pumping of the blood through the cardiovascular system. And as a summary, the SA node's higher intrinsic rate of action potential generation compared to the AV node and Purkinje fiber allows it to become the primary pacemaker of the heart in the normal physiological state. When the heart's normal pacemaker, the sinoatrial node, is blocked or dysfunction, other regions of the heart can take over as the pacemaker. This is called an ectopic pacemaker, as it is generating a heartbeat at a location other than the SA node. If the SA node is blocked, the atrioventricular node takes over as the pacemaker with a rate of 40 to 60 beats per minute. If the AV node is also blocked, the Purkinje fibers in the ventricles become the pacemaker with a rate of 15 to 40 beats per minute. When the Purkinje fiber become to pacemaker after an AV node block, there is a significant delay, 5 to 20 seconds, before the ventricle are activated. This delay can cause the heart to stop pumping effectively, leading to a lack of blood flow to the brain and resulting in a fainting or loss of consciousness, known as Stoke-Adams syndrome. This picture shows that there are the different shapes of action potentials in the different cardiac chambers, for example, atria, ventricle, and nodes, which I explain in the next slides. These shapes show the ventricular action potential. There are 4 steps in the ventricular action potential: 0, 1, 2, and 3. As you see, the resting membrane potential in the ventricular myocyte is around minus 90 millivolt, and an action potential from the Purkinje fiber reaches the ventricular myocytes, causing the opening the fast voltage gated sodium channels. This rapid influx of sodium depolarized the cell membrane to around plus 20 millivolts. And there is a plateau phase. The depolarization activates voltage-gated calcium channels, allowing the calcium to enter the cell. These sustained calcium influx, along with the inactivation of the sodium channels and the we have a gradually activated of the voltage gated potassium channel with a start of the depolarization. So in the plateau phase we have a entrance of the calcium ions to the cells and exceeds or outward flow of the potassium from the cells. So these ions current creates the plateau phase of the action potential. And the repolarization in this phase, the calcium voltage gated channels closed, and the potassium voltage channels are opened completely, and allowing the potassium to flow out of the cells. These outward potassium currents along with the inactivation of calcium channels leads to the repolarization of the cell membrane back to the resting membrane potential. These shapes show the sinoatrial node action potential are divided into 3 phases. The phase 1 is the spontaneous depolarization pacemaker potential that triggers the action potential once the membrane potential reaches a threshold between minus 40 and minus 30 millivolts. And phase 2 is the depolarization phases of the action potential. This is followed by phase 3 repolarization, and the phase 1 related to activation of the L-type calcium channels, and the phase 3 related to activation of the potassium channels once the cell is completely repolarized at about the minus 60 millivolt, the cycle is spontaneously repeated. In this part of this session, I'm going to talk about the ECG, electrocardiogram. Okay, in the electrocardiogram, there are 3 important waves corresponding to electrical events in the heart: P wave, QRS complex, and T wave. P wave represents atrial depolarization, no atrial contraction. The contraction is a mechanical activation of the heart, and the electrical activity of the heart happen before the mechanical activity of the heart. So the ECG show the electrical events in the heart. So P wave represent the atrial depolarization, and the QRS complex represents ventricular depolarization, and T wave represents ventricular repolarization. You must know the atrial repolarization, which occurs after the P wave, is not clearly visible in a standard ECG recording. It is often obscured by the larger QRS complexes and T wave. The atrial repolarization wave, known as the TA wave, is usually small and merges with the baseline, making it difficult to identify. So while the other major ECG wave, P, Q, R, S, T, are clearly visible and represent important electrical events, the atrial repolarization wave is not easily discernible in a typical ECG. As a reminder, in the normal situation, in unstimulated state, the cell is polarized, meaning the inside of the cell is more negative compared to the outside. When the cell is stimulated, it becomes depolarized, meaning the inside of the cell becomes more positive compared to the outside. The electrical wave in the heart propagates from the depolarized area to the polarized area. This wave of the depolarization starts at the sinoatrial node, spreads through the atria, then enters the atrioventricular node, and finally propagates through the ventricle. The depolarization wave is represented by the P wave, QRS complex, and T wave in the ECG tracing. So the electrical activity in the heart moves from the depolarized to the polarized region, This direction flow of the electrical wave is a key characteristic of normal cardiac conduction. I said that the ECG records the electrical activity of the heart by measuring the voltage difference between the different points of the heart. This voltage difference is generated by the propagation of the depolarization wave through the heart. When a part of the heart is depolarized and another part is still polarized, there is a potential difference between these two regions. This potential difference creates an electrical current that flows from the depolarized region to the polarized region. It is this flow of current that is detected by the ECG electrodes and recorded as the various wave P, Q, R, S, T on the ECG tracing. If the entire heart wave either completely depolarized or completely polarized, there would be no potential difference and hence no detectable current flow. And this would result in a flat or isoelectric ECG. ECG electrodes are the conductive pads that are attached to the skin. There are the sensors that detect the electrical activity of the heart. The electrodes convert the ionic currents generated by the heart into the electrical signals that can be measured and recorded. The ECG leads are the graphical representation of the electrical activity of the heart. Each ECG lead is computed by analyzing the electrical signals detected by a specific combination of the electrodes. The ECG leads provided different views of the heart electrical activity dependent on the positioning of the electrodes. Common ECG leads include lead 1, lead 2, lead 3, AVR, AVL, AVF, and the precardial leads V1 to V6. The standard 12-lead ECG represents the heart's electrical activity recorded from electrodes placed on the body surface. Provides 12 different views of the heart's electrical activity. P-wave represents the sequential depolarization of the right and left atria. QRS complex represents the simultaneous depolarization of the right and left ventricle. T wave represents ventricular repolarization, and U wave represents after depolarization in the ventricle. And we have a ECG interval, PR interval, time from atrial depolarization, P wave, to ventricular depolarization, QRS. QRS duration of the ventricular muscle depolarization. QT interval, duration of the ventricular depolarization and repolarization. PR interval, duration of the ventricular cardiac cycle, indicator of the ventricular rate. PP interval, duration of the atrial cycle, indicator of the atrial rate. This comprehensive understanding of the standard 12-lead ECG and the meaning of its various components is crucial for interpreting cardiac electrical activity and diagnosing potential heart conduction. An interval in an ECG is a duration of time that includes one segment and one wave. Segment in an ECG is a duration of the time between two waves, from end of wave and onset of another wave. The 12-lead ECG provides information about the heart's electrical activity in three approximate orthogonal directions: right, left, superior, inferior, anterior, posterior. Each of the 12 leads represents a particular orientation in this 3D space. For example, lead 1, right to left, lead 2, inferior to superior, and lead V1 to V6, anterior to posterior. Understanding this spatial orientation is crucial for interpreting the ECG and identifying the location of the potential electrical abnormalities in the heart. The different lead placements allow the ECG to capture different views of the heart's electrical activity, providing more comprehensive assessments. This slide shows the bipolar limb leads in the frontal plane of the standard 12-lead ECG. The bipolar limb leads include lead 1, lead 2, and lead 3. Lead 1 represents the right and left or lateral orientation of the electrical activity of the heart. RA means right arm, and LA means the left arm. And the lead 2 represent the superior inferior orientation and show the right arm to left leg. Difference voltage and the electrical activity happen between two areas. Lead 3 show also represent the superior inferior orientation and show the electrical activity between the left arm to left leg. These are bipolar leads, meaning they measure the potential difference between two electrodes. The leads provide information about the heart's electrical activity in the frontal plane or coronal plane of the body. Lead 1 represents, I told you, the right, left, or lateral orientation. Lead 2 and lead 3 represent the superior, inferior orientation. Enthoven's law states that the potential difference between any two limb leads is equal to the sum of the potential difference between the other two limb leads. Lead 2 equal lead 1 plus lead 3. This relationship is based on the fact that the three limb leads 1, 2, 3 form a triangular configuration known as Enthoven triangle. The vertices of this triangle represent the locations of the three limb electrodes: right arm, left arm, and left leg. The triangle can be helpful in the identification in incorrect placement of leads. Correct placement of leads can lead to error in the recording, which can ultimately lead to misdiagnosis. If the arm electrodes are reversed, lead 1 changes polarity, causing lead 2 and lead 3 to switch. If the right arm electrode is reversed with the legs electrode, lead 2 change polarity, causing lead 1 to become lead 3, and vice versa. A reversal of the left arm and leg caused a change in polarity of lead 3 and switching of lead 1 and 2. As a summary, the Entowin triangle represents the frontal plane of the heart's electrical activity. The 3 limb leads are arranged in a triangular configuration, and Entowin's law states that the potential difference between any 2 limb lead is equal to the sum of the potential difference between the other 2 limb leads. The another type of the leads is unipolar chest leads are arranged in the horizontal plane and provide information about the electrical activity of the heart from different angles. Lead V1, V2, and V3 are positions on the anterior chest wall, moving from the right to the left side. They provide information about the posterior to anterior electrical activity of the heart. And the lead V4, V5, and V6 are positions on the lateral chest wall, moving from the right to the left. They provide information about the right to left electrical activity of the heart. The placement of these unipolar chest leads allows for a comprehensive assessment of the electrical activity of the heart in the horizontal plane, which is crucial for diagnosis of various cardiac conditions. And you must know, each electrode records the electrical activity of a part of the heart muscle that is placed under it. The QRS direction in unipolar ECG leads are different. Lead 1 and V1 and V2, the QRS direction is negative. These leads are positions near the base of the heart. The depolarization wave moves away from these leads toward the apex, which aligns with the electronegativity of the heart electrical activity. And leads V4, V5, and V6 QRS direction is positive. These leads are closer to apex of the heart. The depolarization wave moves toward these leads, aligning with the electropositivity of the heart electrical activity. The augmented unipolar limb leads are part of the standard 12-lead ECG, provide additional views of the heart electrical activity, AVR, AVL, and AVF. AVR, augmented vector right, placed in right arm, views the heart from the right shoulder. And AVL, augmented vector left, placed in left arm, views the heart from the left shoulder. And AVF, augmented vector foot, placed in left leg and views the heart from the foot directed toward the inferior part of the heart. The 3 augmented unipolar leads coupled with the 3 standard bipolar limb leads comprise the 6 limb leads of the ECG. These 6 leads record electrical activity along a single plane termed the frontal plane relative to the heart. Using the axial reference system and these 6 leads, one can define the direction in the frontal plane of an electrical vector at any instant in time. If wave of depolarization is spreading from the right to left along the 0-degree axis, then lead 1 will have the greatest positive amplitude. Lead AVF will have the greatest positive deflection when the direction of the electrical vector for depolarization is directed downward, plus 90 degree. If a wave of depolarization is moving from left to right at positive 150 degree, then AVL will have the greatest negative deflection according to the rules for ECG interpretation. The heart generates electrical impulses that propagate through the myocardium in a specific direction during each phase of the cardiac cycle. This flow is not random. It flows a defined part of the reflects the physiological and anatomical structure of the heart. In this analysis, the electrical activity of the heart can be represented using a vector. A vector is depicted as an arrow. The direction of the arrow indicates the path of the electrical current flow. The arrow points toward the area of positive electrical potential. The length of the arrow corresponds to the magnitude of the electrical potential or voltage. A longer arrow signifies a stronger electrical impulses. The electrical potential generated by the heart's current flow can be understood in terms of voltage. The voltage reflects the strength of the electrical signal, which is essential for the proper functioning of the heart's electrical conduction system. During the cardiac cycle, which include phases such as atrial systole, ventricular systole, and diastole, the direction and magnitude of the electrical vector changes. For example, in the atrial systole, electrical activity spread through the atria generates a vector that points toward the ventricle. Ventricle systole, the depolarized of the ventricles produce a vector directed toward the apex of the heart and then back toward the base. And diastole, the heart relaxes and the vector returns to baseline as the heart prepares for the next cycle. So, as you know, a vector is an arrow that points in the direction of the electrical potential generated by the current flow, with the arrowhead in the positive direction. Also, by convention, the length of the arrow is drawn proportional to the voltage of the potential. The instantaneous mean vector represents the overall direction and magnitude of the electrical potential generated by the heart at a specific moment. It is a crucial concept in understanding how electrical signal propagate through the heart muscle. This shape shows the vector is typically illustrated as a long black arrow. The vector points from the base of the heart, the top part where the atria are located, toward the apex, the bottom tip of the ventricle. This direction is significant because it reflects the normal pathway of electrical conduction during a heartbeat, where the electrical impulses travels downward through the ventricle, facilitating their contraction and their effective pumping of the blood. The length of the instantaneous mean vector correlates with the magnitude of the electrical potential generated by the heart. A longer vector indicates a stronger electrical signal, which typically occurs when a large amount of current is flowing through the heart muscle during depolarization. The vector direction is established from a reference point of 0 degree, which is directed to the left of the observer. The measurement of the angles for vector follows a clockwise rotation. 0 degree vector pointing horizontally to the left, plus 90 degrees vector pointing straight down, and plus 180 degrees vector pointing horizontally to the right from left to right, and minus 90 degrees or plus 207 degrees vector pointing straight up. The mean QRS vector represents the average direction of the electrical activity during the depolarization of the ventricles in a normal heart. In a healthy heart, this vector is typically around plus 59 degrees. This means that the overall electrical activity during the depolarization wave is directed slightly downward and to the left when visualizing the described coordinate system. The axis of each lead is crucial for interpreting the ECG. It helps clinical understanding the direction of electrical impulses in the heart, which can indicate normal function or reveal abnormalities such as axis deviation, hypertrophy, or ischemia. By analyzing the axis of the leads, healthcare providers can assess the heart's orientation and detect potential issues that may require further investigation or intervention. For example, in the left bundle branch block, or LBB, the signal reaches the right ventricle earlier, and the right ventricle becomes depolarized or negative earlier than the left ventricle. As a result, the direction of the vector will be towards the left ventricle. For determining axis of the heart, please draw lead 1 perpendicular to AVF. After should measure the QRS voltage in lead 1 and AVF, then manually calculate the heart axis angle. As you see, this picture shows the normal heart axis and right or left deviation. For estimating heart rate using large squares, the heart rate equal 300 over or divided to number of the large square between R wave. This method is based on the fact that there are 300 large squares in 1 minute. For example, if there are 4 large squares between R wave, the heart rate equal 300 divided 4 equal 75 beats per minute. Additionally, for estimating heart rate using a small square, the heart rate equal 1500 divided number of small squares between R wave. For example, if there are 10 small squares between R wave, heart rate equal 1500 divided 10 equal 150 beats per minute. Okay, the topic of cardiac physiology has come to an end. If you have any question, ask in the Telegram channel.